staff are interested in hearing about. And so one of the topics that we keep hearing that people are interested about is about prevention of cardiovascular disease and high blood pressure. And that's why today we're really happy to have one of the world's experts here to speak with us. And I'm happy to introduce to you Dr. Professor Michael Weber. He's Professor of Medicine at the Downstate College of Medicine of the State University of New York. He received his medical degree from Sydney University in Australia, and he is his career has been focused on hypertension and preventive cardiology. He has been involved in many clinical trials that works on hypertension and on drugs, as well as been very involved in developing the ambulatory blood pressure monitoring, which is a technique now that is really recommended by major guidelines committees around the world. Dr. Weber was also founder and served as president of the American Society of Hypertension, as well as the American Society of Hypertension Clinical Specialist Accreditation Program. He was chair of the writing committee of the 2014 ASH Hypertension Clinical Practice Guidelines, and he is also a member of the executive committee of the International Society of Hypertension. He's currently on board of the World Hypertension League and was the editor-in-chief of the Journal of Clinical Hypertension. And he currently serves on the steering committee of several national and international clinical trials. He has authored over 500 articles in peer-reviewed literature and was author and editor of 16 books. So the way we typically do these sort of talks is that we start off with a really short presentation by our speaker, and then we will move on to a facilitated discussion where I will ask some questions on behalf of all of you to our esteemed speaker, and then we'll move on to the last 10 minutes to some questions and answers on the chat. So if you have any specific questions and answers that you'd like to get answers to, just please put it on the chat. We'll try to run through it very quickly right at the end. So Dr. Weber, over to you. I'm not sure if you'd like to make a few remarks before we share the screen, but over to you, please.
Well, thank you, Esther, and let me say what a pleasure it is to have this opportunity to speak to so many friends and colleagues at the United Nations. It's just an interesting thing for me that when I drive from my home to my work at the medical school, I actually go right past the United Nations building on First Avenue in New York. So for me, this is a very special way of connecting to people that I at times must get very close to. Though, of course, I realize that many of you are working throughout the world. And that's a particular pleasure, of course, to have the opportunity of connecting with people who are in many areas where hypertension and other cardiovascular conditions really present a major problem. It has become, in many ways, the biggest cause of premature death and disability that we deal with worldwide. And Esther, if we could share the screen.
Sure.
Let me start by showing just a few background pieces of information. I think some of them may surprise you a little bit. Let's see if we get our screen going here, because
Yes.
I do want to show you.
Can you see the screen?
I can see a screen. It's though originating from you, happening now, how to prevent and manage hypertension, but it doesn't. It's not my slides.
Oh, okay. Because I can see it on my side. Let me check again. Can you see it now?
Yes, that's it. That's perfect.
Okay, good. All right, great.
Well, thank you again, Esther.
No
So I wanted to start by simply making the point that sometimes we talk about high blood pressure and sometimes we say hypertension, but it means exactly the same thing. Hypertension is just the medical term. High blood pressure is what most people call it. It's identical. The two terms mean the same thing. And you can see in red on this slide, I put in a statement that the World Health Organization has announced that hypertension has become the leading cause of premature death and disability worldwide. And it's the first time that a non-communicable disease, something that's not an infectious disease, has been responsible for such a major health problem. High blood pressure is everywhere. It's the great equalizer. Unlike some of the infectious diseases, which tend to be located in certain areas of the world, hypertension is found in every community, in every country, in every continent. And the difference between large affluent countries and smaller, perhaps low-income countries is minimal. It's roughly the same number of people are going to have high blood pressure and suffer from the consequences of high blood pressure. Okay, let's go to our next slide, which shows what high blood pressure can lead to. What are its consequences? Well, unfortunately, it does shorten life. It causes strokes, both the thrombotic or strokes, or the strokes that are caused by clots in the brain, as well as the sorts of strokes that are caused by bleeding in the brain. Hypertension leads to heart attacks and to heart failure. It leads to kidney disease. It leads to disease of the peripheral arteries, particularly in the legs, where people suddenly find they're not able to walk very well. And more recently, we've become aware that high blood pressure leads to dementia, Alzheimer's disease, premature inability for aging people to function properly. So a whole list of very serious issues that can be linked to high blood pressure. So let's go on and have a look at what it looks like. Now, these are data from the United States, but as I've already said, these sorts of data could be applied in just about every country of the world and in every continent. I'm very interested in what's going on, for instance, in Asia. I'm very supportive of Asian research, which is doing amazing things in hypertension. And you know what? They are finding in Asian communities data that are very similar to what we find in the West, very similar to what's found everywhere, even Africa, where, again, things may be a little bit different in terms of the environment, in terms of economic circumstances. The same story is basically true. Hypertension, we define it as having a blood pressure higher than 140/90. The top number, the 140, is the highest blood pressure that we have. As the heart beats, the blood pressure is higher. Then while we're waiting for the next beat, it goes down to 90. In this particular example, 140/90 is as high as the blood pressure can be without it being called hypertension. Anything more than 140/90 is too high and carries with it the risk of strokes, heart attacks, and all the other bad things I was just talking about. Ideally, we would like the blood pressure to be 130/80. And even better than that, 120/80. We really like blood pressure to be as low as possible. When we're children, our blood pressure is quite low. It's less than 100/60. And if we could keep it that way throughout our lives, we would be so much better off. But for the reasons we'll talk about in a moment, that doesn't usually happen. Without treatment, about a third of all people in the United States, and you can say that for any country in the world, have high blood pressure. And one of the reasons for that very high percentage is that the prevalence of hypertension increases as we get older. So by the time we're 60% of the people in our population have high blood pressure. By 70, it's about 65% of men, 75% of women have hypertension. And frankly, by the time you get old enough into your 80s, just about everybody has hypertension. Amazing, isn't it? How can you call something that's so common a condition or an illness or a disease if everyone has it? But it is, unfortunately, an inevitable part of aging. We have studied it. Why does it happen as we get older? It's something to do with stiffening of the arteries, and we haven't figured out exactly what the trigger is for that. When we do, it's going to be a huge step forward. So let's go to our next slide. which just shows again what I just pointed out, that as we get older, see down in the when we're in our 20s and early 30s, only about 10% of people have hypertension. But then as we get older, every 10 years, you can see it going up and up and up into the 70s. And if we had the data that we now have that go into the 80s and 90s, people living that long, hypertension is just about universal. All right, let's move forward to our next slide. This is a sobering piece of information, and it's from the United States. It's true everywhere. And that is, if you look at the left, that shows the number of people who've got hypertension, but whose blood pressure is now normal because they are being treated or because they're doing healthy things that I'm going to talk about in just a moment. And you can see that things were improving for about the last 15 to 20 years, and got to about 50% of all people with hypertension actually having their blood pressure under control. And oh dear, in the 4 or 5 years from 2014 to 2018, the rate of control actually deteriorated. How do we explain that? And if we go to the right side of the slide, that other little graph shows just those people who are actively being treated by a doctor or another health professional for the hypertension, maybe with medicines, with lifestyle changes, whatever it might be. And there you can see that as many as 60 to 70% of people had their blood pressure reduced to less than 140 over 90. But again, the last few years, things have turned the wrong way. Why is that? Are people getting bored with taking their medicines? Are people forgetting that perhaps their weight or other issues are a big problem and why their pressure is so high? We're not sure of what's going on, but it's a very troubling finding. Let's go to our next slide. I wanted to show you this, and it's just one example of literally hundreds of small blood pressure devices that are available worldwide. You can get them in every country of the world. They're small, they're very easy to use. You can learn in 2 minutes how to use it, and it's a very useful tool for measuring blood pressure. In the old days, we used to have to use a stethoscope. We had to have a device we called a sphygmomanometer with mercury in it. It was a complicated business when I started out measuring blood pressure. Now we have these small, very useful devices that many people have in their homes throughout the world. And we recommend that we use these sorts of devices even in clinics, because it means that even inexperienced health workers, particularly in low-income areas, can quickly be taught how to measure blood pressure and advise their patients. So let's move on to the next slide. What causes high blood pressure? Well, I've already told you one big thing: getting older, being overweight. And that's a huge problem, again, worldwide. People used to say, oh, it's only in America and Western Europe that we got a weight problem because those people eat far too much, but the rest of the world doesn't have that problem. Absolutely not true. Again, throughout the world, being overweight or obese is a serious problem. We should never forget that eating healthy is sometimes expensive, because eating healthy means fresh fruits and vegetables, fish rather than meat. Just eating things that are relatively low in calories and fresh and healthy, those sorts of foods are quite expensive. You know, here in this country, how do you feed a family if you don't have much money? You go to McDonald's and you buy hamburgers, because you can get what they call a value meal with a big hamburger and French fries or chips and a Coke or something like that for relatively little money. You can feed your children on that and they're happy with it, but it's not necessarily what you would want to do if you're really thinking about preventing high blood pressure and doing other healthy things. Eating too much salt. That is a huge problem all over the world. In the old days, salt was so important, wasn't it? Because that's how you preserved food, but not now. We don't need salt for that so much. And we eat way too much salt, 3, 4, 5 times as much salt as we really need. And that's often a cultural thing. Some countries, every dish that's prepared has salt in it. And it's something that's been done for generations, maybe for hundreds of years. We have to work hard in communities to change people's use of salt. Too much alcohol. And I know we've had a program in this series on alcohol. And we know that alcohol, not just 1 or 2 drinks a day, that seems to be acceptable. But people who drink more than that, the alcohol contributes to the high blood pressure as well. And importantly, not being physically active. And if we don't walk enough, if we don't exercise in different ways, if we don't use our bodies to do things and to burn calories and to exercise our muscles and make our heart work a little harder from time to time, that also leads to high blood pressure. Now, there are other causes of high blood pressure, and I'm not going to talk about them much. These are sometimes called secondary hypertension and caused by some genetic or inherited abnormalities of the kidney or the adrenal glands. Sleep apnea, by the way, is one of the secondary causes of high blood pressure. But most high blood pressure, we call it primary hypertension or essential hypertension. Most people with hypertension don't have any of those underlying causes. They are hypertensive for the reasons on the top of the slide. The fact they're getting older, they weigh too much, eating too much salt, and so forth. All right, let's go on. And I think this should be the important slide. How do we prevent hypertension? Well, we basically deal with all the things I've mentioned. And you can do it in your own lives, of course. Have a more active lifestyle. Walk, swim, exercise in some way. Climb, whatever it is you enjoy doing. Ride a bicycle if you have a bicycle. Anything that helps you to burn calories and get your body moving is going to be helpful in preventing high blood pressure. Reduce salt in the diet. I've mentioned that already. Try and keep your weight under control. Easy to say. I know we all have a compulsion to eat. We get hungry. We tend to overeat. And I think there's some internal mechanism that makes us want to eat more food than we really need. So I'm not saying it's easy to keep your weight under control. I know it's not easy. I have so many patients in whom controlling the weight has been a real problem, but you have to do the best you can. Be moderate with alcohol, and very importantly, check your blood pressure regularly. So if your pressure is getting higher, and it often will, no matter what you do, we'll know that something has to be done. And as I've already mentioned, you can now get access to measuring devices that most people can afford in their homes. If not, there are plenty of clinics that will happily measure blood pressure and let you know if it's okay or whether it needs some sort of treatment. And the last thing I wanted to point out is to remember that treatment of high blood pressure, which is usually done by doctors or other health professionals using medicines, and there are many medicines now, and the World Health Organization has listed a whole bunch of what they call essential medicines for hypertension. They're available, they're inexpensive. These medicines are very effective in preventing heart disease, strokes, and kidney disease. And you know what? They don't have side effects, most of them. They're very easy medications to take. So no excuses for not taking medicines for high blood pressure if you need them. So that's what I wanted to say to start off, Esther, and let me give it back to you.
Great, thank you so much. That was fantastic. I think it answered a lot of questions already, but maybe let me just go into more depth on some of them. And let me just see if I can. Mike, can you just spotlight myself and Dr. Weber side by side?
Yes.
Thank you.
It's done already.
Okay, great. All right, so maybe my first question is really more personal. How did you get into specializing in this area? Is there a motivation? I'm just curious. I always ask this for many speakers. Yeah.
Yes, well, it's interesting because as you might imagine, when I went into medicine and became a doctor, I wasn't quite sure what I wanted to be a specialist in. And then I got particularly interested in heart disease, and I applied for a job. I was still in Sydney, which was where I grew up and went to medical school. And the one job that was available was for a senior doctor who was doing research in high blood pressure, because in Australia, just as in so many other countries, it was becoming recognized as a huge problem. And that's where I learned about high blood pressure and started doing research in it. I worked in the lab. I did a lot of very basic science work. I did a PhD as well as having my medical degree, learning how the kidney regulates blood pressure and how blood pressure can be controlled by different mechanisms. So that's how I started out. And somehow, I wasn't sure if that's what I was going to finish up doing, but you know, you start doing something, it's going well, and suddenly you realize you're not a young person anymore. You've been doing it for many years, but you're enjoying it, and you're being successful, and that's how I've got where I am.
Great, thanks so much. It's really interesting to hear that. So a few questions I have. In terms of, you mentioned that as people age, they almost definitely will have an increased high blood pressure. And over the years, I mean, so much research has been done on hypertension. Has this kind of rate reduced in the, in the population in terms of, or it's still increasing, the prevalence of hypertension, despite kind of everything we've learned and know about it?
You know, Esther, it's remarkable, but we have not reduced the prevalence of hypertension. In fact, it's getting higher all the time for two reasons. First of all, the population, thankfully, is living to an older age. So more people get old enough to get the high blood pressure. And secondly, we have this real problem of overweight and salt consumption. And although every doctor knows, and I suspect even most lay people know, that being overweight is not good, and they know that eating too much salt is not good, our ability to change people's personal habits like that is not as strong as you would imagine. So even with governments making statements, and even now when you buy food in shops, there's usually on the back, it lists the ingredients of the food, including the salt. And so people should know that they're eating too much salt, should know they're eating too many calories, but somehow we've not been able to deal with that problem at all, either in affluent countries or in the low middle income countries. It's the same story. People like having salt in their food, and they like eating a lot of food. And that's unfortunately something we have not yet been able to control. So yes, I was shocked years ago when I heard that 20% of people in the population had hypertension, and now I'm talking about 30%. And that's in the United States, where we have a lot of publicity about hypertension, a lot of public service announcements on television and radio, a lot of communities, people of different ethnicities focus on it, a lot of places of religion, even churches and mosques and other places have efforts to measure blood pressure in their own communities, in their own congregations. Despite all of that, we've still not made as much of an effort as, or at least we haven't achieved as much success as we should have. And ultimately, it gets down to individual people, doesn't it? It's each one of us has to see what our blood pressure is and do whatever we need to do to try and make it as normal as possible.
So you talked a lot about the role of, let's say, nutrition and exercise. What about the role of genetics as well as psychosocial elements? Does it come to play as much, or it's really about nutrition and exercise mainly?
There are some genetic forms of hypertension. And yes, if you look at family history, there is a trend for if your parents had high blood pressure at an early age, you tend to have high blood pressure at an early age. If you've got a bad family history where a lot of people have had strokes or heart attacks, again, that tends to follow that family history. But is that genetics, or is it simply that if your parents eat a lot of salt and eat a lot of food and do not have a very active lifestyle, you're probably going to do the same thing as your parents, right? We tend to learn our habits from our parents, from our close relatives. So it's hard to know what's inherited, what's genetic, or what is just simply learning from the older generation, seeing what they do and copying them. So that's
right.
Yeah.
And how about the role of stress and kind of psychosocial influences?
Well, that's a great thought, because many people think when we say hypertension, the word tension, of course, can be a mental or emotional word. And so is it because we are stressed out? Is it because we're worried or upset about things or angry about things? Well, the answer is, when we are upset and angry, sometimes our blood pressure does go up a little bit and our heart rate goes up a little bit, and that's normal. We still have some of our basic instincts, and the body, when it gets upset, even for something that's not a physical threat, it could just be an emotional issue, tends to still respond in the same way and do everything it can to make the body ready to fight back in some fashion. But as a real cause of high blood pressure, long-standing hypertension, amazingly not so. People have looked at people in high stress jobs, if you're a policeman or a fireman or working as a nurse in a hospital where you're dealing with so many patients and you really don't have the resources to deal with them, that's very stressful. It doesn't turn out, though, that people doing stressful jobs are more likely to have high blood pressure than people who have what you might call easier or less stressful jobs. So there really isn't much in that story. We used to think there was, but it's not quite where we felt. I'm sure there are some people who, because they are subject to stress, deal with their stress by eating too much. Then they gain weight, and then that leads to the pressure going up. So in that sense, yes, stress could be a cause or a contributor to high blood pressure, but not directly.
Got it. Another question I have in terms of, you mentioned that as a great cause of premature deaths and all that. Could you explain kind of for lay people, the relationship between hypertension and strokes and heart attacks? How does it develop? The mechanism?
Well, what happens is high blood pressure puts a stress or puts pressure on our arteries. And if you think about it, it's the arteries that are taking the nutrients and the oxygen that we need to the brain, to the walls of the heart, to the kidneys, to all of our important organs. High blood pressure unfortunately has an effect on our arteries, the roads, the channels by which the blood with all its nutrients gets to our essential organs. And what happens is the high blood pressure makes the walls of the arteries get thicker and stiffer. And so over time, it's a little bit like plumbing in a house. The pipes, after a while, after years, become less effective because they start to accumulate waste and other elements on the inside of the pipe, and so there's less room for water to run through. The same with our arteries. We accumulate cholesterol, we accumulate fibrous tissue, we accumulate all sorts of bad elements in the walls of our arteries because of the high blood pressure. It's often called atherosclerosis. That is the technical term. Athero means arteries, and sclerosis means stiffening, right? It's, we have fancy names for simple ideas. And as the arteries get stiffer, they in turn make the blood pressure get higher. And then when the blood pressure gets higher, it makes the arteries get stiffer, and it's this vicious cycle. So now, if you think about the brain, two things are going on. The brain is being subjected to higher and higher blood pressure, and in some ways, not enough good blood or not enough oxygen and other nutrients are able to get to it. So two things can happen. If the pressure is very high, it can actually burst one of the arteries in the brain, and there's a bleed in the brain, and that damages the area of the brain around it. And that, of course, is a stroke. And that's obviously a serious event. The other thing that can happen is that vital arteries in the brain, as time goes by with the high blood pressure, the internal size of the artery where the blood goes is getting smaller and smaller. The artery is getting stiffer and stiffer, and then it just clots. And suddenly there's a whole part of the brain that depended on that particular artery that's not getting blood anymore, and that part of the brain will die. And that's, again, a stroke. It's a different mechanism. It's not that the blood has burst through the artery, it's just simply that the artery has totally stopped up. It's like plumbing. It's really, people talk about plumbing, and that's exactly what we have. It's like a pipe in the sink is clogged up, and that's what happens to the arteries in the brain. And the same thing can happen in the wall of the heart. Our heart muscle depends on the coronary arteries. The coronary arteries provide oxygen and nutrients to the wall of the heart so it can beat and keep us alive. And unfortunately, the coronary arteries are very, very vulnerable to things I'm talking about. They get stiffer, they get atherosclerosis, they get the size of the artery gets smaller and smaller and smaller and smaller, so that in the end we get a heart attack. There's just not enough blood to support the wall of the heart to allow it to beat properly. We have a heart attack, and that can have a very serious outcome. And then the other thing that's going on in the heart, and forgive me if I'm getting too technical, is when you think about it, it's the heart that provides our blood pressure. So when our pressure gets higher and higher, the heart has to work harder and harder. And the heart is a muscle. So when a muscle works hard all the time, what does it do? It gets bigger, right? If you work your arm all the time, you get a bigger muscle in your arm. If your heart has to work hard all the time, the heart muscle gets bigger and bigger. But unfortunately, the supply of blood and nutrients to that hard-working heart and that bigger heart muscle doesn't increase along with it. So it's not a healthy thing when your heart gets large, and it starts to fail, and we get what's called heart failure, which is dramatically growing in frequency throughout the world. It's a huge problem here in the United States and everywhere around the world. Heart failure, for the simple reason that our hearts have gotten bigger because they're pumping to keep up our hypertension, and the heart muscle is just not getting enough oxygen to do its work. And so that's another big problem. When you get heart failure, you get short of breath. You can't even lie down. You have to sit up so you can catch your breath. You have very limited exercise capacity. Many people with heart failure can't even climb one flight of stairs. They can't walk more than maybe 40 or 50 meters, sometimes not even that far, without having to stop and get their breath. So that's another consequence of the high blood pressure.
Great, thank you. We have a lot of questions. I'm just gonna ask two more questions, and then at 9:40 we'll segue to all the questions that you have on the chat. So two things. One thing, you mentioned that hypertension is the great equalizer. So you mentioned that it could be a Western nation versus a lower resource country, that they have a similar rates of hypertension. However, if nutrition and obesity and all that is the cause of hypertension, wouldn't it make sense that it would be higher in the, kind of higher income kind of countries that have a lot of this type of conditions?
Well, I think that was the way we thought about it several years ago.
Mm-hmm.
But the world has changed so dramatically, Esther, in the last 20, 30, 40 years. I remember the first time I visited China, maybe that was about 30 years ago. Everyone was excited because there was a Kentucky Fried Chicken franchise somewhere near Tiananmen Square in Beijing. And that one little outpost of American eating. Now, when you go to China, every corner has a fast food outlet, and the same throughout the world. It may not be American fast food, but it's food that's inexpensive for people to buy. They like it because it's got salt and fat in it, which frankly people do enjoy eating, and so. The things that used to be more common in affluent or wealthy countries are now seen throughout the world. And unfortunately, that's a growing problem everywhere. As I mentioned before, unhealthy foods tend to be less expensive than healthy foods. And so, unfortunately, we're dealing with a growing problem of overweight and obesity in every country, even the poorest of countries, where the resources are minimal. Hopefully we'll get to change that. But sometimes it's no good me saying to somebody who can't afford to buy healthy food, eat healthy food. If they can't afford it, they can't afford it. And I think we have to recognize that. And I think when we talk about health, we have to think about not just medicines and surgery and things like that. We have to think about basic social issues. How do we enable people who have limited personal resources to get access to food that is more healthy and better for them and their children?
Mm-hmm. And this moves on to my last question. So we talked a lot about, what to avoid. So for example, salt and fats and all that. But is there any studies that show that, certain types of food is protective? I assume fiber, vegetable and stuff like that. But is there any specific studies that show kind of the protective effects of certain specific exercises or food groups or?
Well, as far as food is concerned, yes, as you say, high fiber foods, foods with potassium in them, which is a number of the green salad type foods, is very good. When it comes to protein, it doesn't have to be animal protein. It can be vegetable protein. Fish is probably preferable to meat, but it's easy for me to sit here and say that, but if you live in a country which doesn't have access to fish or very limited access to fish, that's not very helpful for me to say, is it? Some meats are perhaps healthier than others, and beef, which is a staple in many countries, and certainly here in the United States, I enjoy eating beef, but when I eat it, I recognize that it's probably not as healthy as eating fish, and it's probably not as healthy as even some other kinds of meats. For instance, pork, and of course, not everyone will eat pork for religious and other reasons, but where pork is available, it is a relatively healthier type of meat. Those sorts of considerations come into it. But the most important thing we can do that we do have control over is the amount of salt that we use in the cooking. And there are some communities where the salt use is so high, and particularly where they use sauces that have very high salt content, like soy sauce, for instance, that we see in certain countries young people having strokes. Now, here in the United States, if I see a person under the age of 40 or 50 who's had a stroke, I'm rather surprised because it's really quite uncommon. But if I go to some countries where salt consumption is very high, they have strokes in people in their 20s and 30s. It's really very unfortunate, and it's very much linked to salt. We really have to work hard because, again, you have to. If you suddenly say to somebody, stop eating salt, it's difficult because you're used to that flavor. You take it away, this food is nothing. I can't taste it. It's nothing there. So little by little, you have to reduce salt. And one experiment that the British government has done is they've told all food manufacturers to reduce the amount of salt in their processed food by a small amount every year. Maybe it's just 5%, so that no one really notices that there's just a little less salt. And over 10, 15, 20 years, we might be able to get the whole population accustomed to eating less salt than before. Those are the sorts of things. And so we need, it's not just those of us in healthcare, we need to get our friends in politics and public health and all the various social organizations to understand this and try and work together to, on a population basis, encourage a reduction in salt. That I think would be very helpful.
Great, thank you. So I'm going to move on to the question and answers. We have about 15-20 minutes, and there are lots of questions. So we're going to do kind of a rapid fire here, Dr. Weber, and we'll see if we can get through as many of these questions as possible. All right, the first one about drinking too much alcohol as one of the causes of developing hypertension. Can you tell us a little bit about that?
Yes, alcohol, unfortunately, if you just drink 1 or 2 drinks a day, that's fine. It does not have an effect on blood pressure. In fact, it may slightly reduce blood pressure, at least for an hour or two. But if you drink too much alcohol, it stimulates sympathetic and other activities in the brain. And over time, that raises blood pressure. So people who drink too much are much more likely to have hypertension. An occasional social drink is fine, no problem there. It's the people who drink 3, 4, 5, 6 drinks a day. Unfortunately, there are many people like that. They are the ones who have to be concerned about alcohol.
Great, and the same question for coffee as well. Is coffee good or bad for hypertension?
People have argued about that, Esther, for a long time, which tells me that the evidence isn't that strong one way or the other. And of course, people, when they talk about coffee, they're thinking mainly about caffeine. And yes, caffeine can raise the pulse rate a little bit. That makes the heart work a little harder. Does that raise the blood pressure? It's been pretty hard to get strong evidence on that. And I suspect 1 or 2 caffeine drinks a day is acceptable. But again, there are many people who drink 5 or 6 coffees a day with caffeine or other drinks that have caffeine. And if you can believe it, there are some brands of commercial drinks that have super amounts of caffeine. People like it because they think it makes them more awake, more alert, gives them energy. I think it's a false energy, but anyway, that is going on. So, but coffee, as most people drink it, maybe 1 or 2 coffees a day, shouldn't be a real problem.
Some questions about the role of medication. Is how much should we try to prevent, and then when do we switch over to medication, and then are these medications taken for life to control blood pressure, or can it be stopped? What is the guidelines here?
The reality, Esther, is that probably 90% of people who have high blood pressure will need medicines to control it. All of the good things we've talked about, losing weight, eating less salt, exercising, all of those good things are helpful. And if we could get our children and young adults to do it, we might be able to prevent or at least delay the onset of high blood pressure. But once somebody has hypertension, has high blood pressure, yes, you can maybe spend 3 or 6 months seeing if by losing weight, eating less salt, exercising more, can you get the blood pressure down into an acceptable level? Sometimes it works, but unfortunately, even when people lose weight, can they keep it off on a long-term basis? It's nice to lose weight and you look better and you feel better and it's terrific. But a year later, have you still kept that weight off? And if you haven't, then you really have to think about perhaps seeing a doctor, getting medicines. The good news is that medicines should be inexpensive, and now they are very well tolerated. It's not a burden to take high blood pressure medicines. And most of the guidelines, international guidelines, worldwide guidelines, are stressing the importance of taking medicines. The World Health Organization, in fact, just put out its own guidelines for treating hypertension, and very much into starting medicines sooner rather than later. You know what you can do, Esther? You can start medicines and get the blood pressure nicely controlled. And then you can, I will sometimes say to a patient, you know, you're doing terrific. I'm really happy with what you're doing on these medicines. Now, if you could only lose some weight or exercise more, maybe we could start to taper down your medicines. Wouldn't that be a nice reward? You can do that with people who've got high blood pressure. But the truth is that I would say close to 90% of people with hypertension will need medicines. But let me repeat again, medicines are relatively inexpensive, and they do not cause side effects in most cases. Most people don't even know they're taking a medicine when they take a high blood pressure medicine. They're very easy.
Okay, another question about portable BP machines versus, you know, what the doctors measure. How accurate is it? Those kind of home-based machines that we buy over the counter.
Oh, you know, that is a controversial area because there are some very ethical companies that make these small blood pressure machines, and they are very accurate, very reliable. And you want to know something? I showed that picture of one of those machines. That's what people can buy and use at home. And we use exactly the same machine in the office, in the clinic. We prefer it. It's more reliable. And it means that no matter who measures the blood pressure, whether I do it or a nurse does it, or one of the other assistants in the office and the clinic does it, it's the same device. It's not my judgment or anyone else's judgment. The machine decides what your blood pressure is. It's very reproducible. It's very reliable. The problem is that there are many cheap imitations on the market, and there's a great importance in, if possible, using machines that have been validated by an international agency. There are 2 or 3 agencies. One is called STRIDE. The British Hypertension Society is another international organization that validates these devices. So if you can check when you are looking at a device, somewhere on the box that it comes in, it should say this has been validated by, and if it looks like it's an important international organization, that's quite good, because some of them are not very reliable. And but they should be available at reasonable cost. And once you have it at home, of course, you can use it for everyone in the family, even share it with your neighbors or your friends or your relatives when they come to visit. So get everyone sort of interested in high blood pressure, looking for it, and when it's found, knowing that something has to be done.
Okay, another question relates to hypertension and diabetes, the relationship between those 2 conditions.
It's a very strong relationship, unfortunately. And high blood pressure, as we've already talked about, is a risk for early strokes and heart attacks and heart failure and kidney disease. And so is diabetes. Exactly the same problems. People with diabetes are more at risk of strokes, more at risk of heart attacks and heart failure and kidney disease. And unfortunately, many people with diabetes also have high blood pressure. First of all, because high blood pressure is so common that if you have diabetes, in your 50s and 60s, there's a very high chance you also have hypertension. But more than that, some of the causes of diabetes are the same as the causes for hypertension. For instance, being overweight. Particularly as you become middle-aged, if you're overweight, your likelihood of getting type 2 diabetes is quite high, and the likelihood of you becoming hypertensive is quite high, and it's being caused by the same thing, the increase in weight. So as you might imagine, most people with diabetes have high blood pressure, and a lot of people with high blood pressure have diabetes. And it's a serious situation. Again, the treatments for diabetes are now far easier to use than they were several years ago. We have a lot of medicines now for people with type 2 diabetes, particularly metformin, that work very well for controlling it. And hopefully we will get a handle on that, because diabetes, the incidence of diabetes in the world is going up quite sharply. It's a very troubling situation.
Same question about the role of hypertension versus dementia. You mentioned that there might be a kind of a causative link there just now. Is that a kind of some early studies that show that? Or?
Yes, there is a relationship between probably all of the what we call risk factors and dementia. So high blood pressure is a predictor, particularly as people who have high blood pressure that's not well managed when they're middle-aged. They seem to be more likely to get dementia. Diabetes is also a problem. High cholesterol or lipid abnormalities is another area of concern for dementia. So it's very important as early as possible in life to get these risk factors, the hypertension and diabetes and so forth, under control as best we can, because the reward is that when people get to be in their 70s and 80s, they are less likely to have dementia. And dementia is becoming a growing problem throughout the world. And it's a devastating condition, as it doesn't just affect the person who has it, it affects their whole family, right? You have an older person in your family who has dementia, it usually means that a younger person almost has to give up their job just to look after their mother, their father, their aunt, whoever it might be. It's a terrible social and family problem, as well as a problem for the patient who has the dementia. And to look after it and caring for these people in institutions, whether it's nursing homes or other care facilities, incredibly expensive. It's unaffordable. Even in the United States, it's unaffordable. So again, the incentive is to do whatever we can to deal with blood pressure, diabetes, all these risk factors, our weight, all of these things, as young in life as possible, so that when we get into our elderly years, we are still pretty healthy.
Thank you. There are a lot of questions about nutrition. So some people are asking whether intermittent fasting shows that it's helpful for reducing or preventing hyperpressure.
Well, people who follow intermittent fasting can get two benefits. And this is still controversial. It's not something that is directly recommended by guidelines. But I think there's some interesting evidence that people who have intermittent fasting do have somewhat better weight control, somewhat better blood pressure, and perhaps somewhat better management of their blood sugar, in other words, their diabetes or or at least the ability to prevent progressing into diabetes. So that's an area that we need to keep an eye on. It's not enough yet in the literature, not enough research done yet where I can say, oh, I would definitely recommend doing it. But I've had some patients, and I know some colleagues who are quite enthusiastic that this could be an appropriate thing to do. I think sometimes our eating habits are based more on convention and social activity than they are on what our bodies really need in terms of nutrition and when it should be taken. And I think as we learn more about that, we may come up with cleverer ways of eating. But that should be happening soon. I hope we'll get more information. It's an important question.
Some questions related to people who are on the medication, on trying to put in a healthy lifestyle, but they're still not seeing the blood pressure coming down. Is there some sort of kind of resistant hypertension, that just nothing works? Or
yes, sometimes that happens, Esther, unfortunately. And we have them not just on 1 or 2 medicines, we have them on 3, then we have to go to 4 and 5 or 6. We do everything we can to make them eat less salt, to try and lose weight, to do all the right things. And maybe 10% of people with high blood pressure are very difficult to manage. The important thing is we should do whatever we can to make the blood pressure as low as possible. So if someone has a pressure of 170, well, that's not good at all. We would like it to be less than 140. But if the best we can do is to get it down to 160 with medicines, that's still a big improvement. They're still significantly less likely to have a stroke or a heart attack or other bad things happen than at 170. So 160 is better than 170. Not as good as 140 or 150, but it's an improvement. And also there's some suggestion that people who reliably take their medicines, even when the blood pressure is not as good as it should be, there may be actions of the medicines beyond lowering the blood pressure that can protect you from strokes and heart attacks and kidney disease. So the key, when we have these frustrating situations where we're doing everything we know to try and control high blood pressure in a patient and it doesn't seem to be working as well as we'd like, the key is to do the very best you can and to really encourage the patient. And this is a big issue, Esther. The main reason that blood pressure is not well controlled when we treat it is because people are not taking their medicines reliably. And sometimes people say, well, that's because they can't afford them. But that's not necessarily true, because even in health plans, and in many countries, people that have government-supplied healthcare, the medicines are provided free of charge or at a very, very low cost. It's not the cost of medicines, it's that people, for some reason, and it's never been well understood, don't always take their medicines. And it's not a burden. Most blood pressure medicines only have to be taken 1 time a day. So even if you're on 3 medicines, so you put 3 pills in your mouth, done, until next day. So it's not an inconvenience. You're not going to get major side effects. In fact, you don't even feel like you're taking medicines. So why aren't people more reliable with taking medicines? I have no idea. I've worried about it for years. We talk about it all the time. Why aren't people adherent to what makes so much sense? Here we are, we're giving you these pills that'll help protect you from getting a stroke or a heart attack or kidney failure. I mean, what could be more of an incentive than that, knowing how well these medicines work? And yet so many people don't take them, and persuading people, helping them to understand. I've already, as a routine, when I start somebody on a medicine, I also, if I can, talk to other people in the family because I might say to a man, you need to take medicines, but I'd like his wife or his daughter or sister or someone or a good friend to know, because they will keep on reminding them and telling them and making sure that they follow the medicine, because that is so important in protecting them from strokes and heart attacks and other serious outcomes.
Okay, two very quick last questions. One is, does aspirin at low dose play any role to try to prevent this? I mean, it's useful for strokes, I understand. So that's one. And then my second question is salt. How much is too much salt, basically? And with that, we're going to end. Yeah. Okay.
Well, aspirin is one of the biggest controversies still in medicine. There's no question that in somebody who has had a bad event, they've had a stroke, they've had a heart attack, they've got problems with the kidney, they've got advanced diabetes. For such people, a low dose of aspirin can be very helpful and protect them from big events, because aspirin stops clots from forming, which is the main cause of strokes, the main cause of heart attacks, and so forth. If on the other hand, people who don't have too much of a high risk going on, aspirin can cause some bleeding. And so they worry that the aspirin may cause a serious hemorrhage from your stomach, or maybe even in the brain. So you don't want to use aspirin in everybody. You want to use it in people where you're really worried that they've already had signs of serious cardiovascular diseases. So that's becoming clearer and clearer. And I think most doctors have a pretty good understanding of when to use it and when not to use it. And you're absolutely right. When we do use it, it's in low doses, usually a quarter of the usual aspirin tablet a day. That's all. How much salt should we eat? In the general rule is we should eat the equivalent of about 5 grams of salt a day, or if you want to say it in terms of sodium, about 2,000 milligrams a day. And it sounds like a lot, but just one bag of potato chips is almost that's your day's allowance right there, or a big part of it. So in the United States, where we try to be good about it, the average person is eating twice as much as they should. They're eating 10 to 12 grams a day rather than 5. In some countries, 15 or 20, particularly countries that have a big culture that's built around a lot of salt in the food. So there's a lot of work to be done there.
Okay, great. Thank you so much. I think we're done with time. It's 10:06, 6 minutes past, but I really appreciate your time, Dr. Weber, and we'll love to have you back. We do have webinars that's focused for the medical practitioners around the world that is serving UN staff, but for the purpose of this is really just for just general UN staff around the world. So thank you so much for your time.
Well, thank you for including me, and I look forward to helping you again wherever I can.
Thank you. Thank you, everybody. And please feel free to sign up for the future series. We would love suggestions for what topics you're interested in as well. We'll put it on the chat if you wanted to just take a look as well. Thank you so much, everybody. Have a good day. Bye-bye.